Welcome to this educational program. This module discusses a surgical treatment for kidney cancer called radical nephrectomy. A separate presentation entitled Understanding Kidney Cancer is also available, and it is hoped that you will have viewed this already. The information in this presentation is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. Radical nephrectomy involves the complete surgical removal of the kidney along with its surrounding structures. It is indicated for localized tumors confined to the kidney in an attempt to cure the cancer, and for advanced tumors with spread beyond the kidney to either control symptoms or to improve the results of other therapy, such as immunotherapy. It should be emphasized here that surgery is the only known treatment at present that can cure kidney cancer. The kidneys are a pair of bean-shaped, fist-sized organs situated on either side of the spine in the upper abdomen and lie behind the bowel and other abdominal organs. They are protected by the lower part of the rib cage and the spine. The kidneys are composed of many different types of tissues and cells, but broadly they consist of a filtering system, the meaty red part of the kidney called the parenchyma, and a drainage system that carries urine from the kidney down to the bladder. The renal parenchyma is divided into an outer part called the cortex, which is the filtering mechanism, and an inner part called the medulla, which is the collecting area for the urine. It is easy to think of the kidney as an organ where blood goes in and urine comes out. Above each kidney lies an adrenal gland, and each kidney and adrenal gland is surrounded by fatty tissue, which is a protective mechanism in place so that the kidneys do not get damaged by trauma such as jarring accidents and direct blows. The fat acts as a shock absorber for the kidney. It also acts as a natural barrier preventing local extension and spread of kidney cancers. Around all of this is a tough fibrous membrane called Gerota's fascia, which is also important in limiting the spread of cancer. Like all major organs, the kidneys are also surrounded by lymph nodes, small glands that play a central role in fighting infection and disease. The kidneys receive blood supply from usually one, but often two or more renal arteries, which arise from the aorta, the largest artery in the body. This is the large blood vessel that takes blood away from the heart to the rest of the body. Blood drains out of the kidney through one or more large renal veins, which then drain into the largest vein in the body called the inferior vena cava, or IVC. This drains blood from the body back to the heart. This drawing shows how the kidneys are surrounded by other organs in the body. On the right, the kidney sits below the liver, next to part of the small bowel called the duodenum, and beneath the right side of the large bowel, or colon. On the left, the kidney lies below the spleen and stomach, beneath the left colon, and just to the right of the tail end of the pancreas. The lungs and chest cavity are also in close relation to the kidneys. This is what the kidneys and other organs look like in a CT scan or an MRI, where the body is viewed in slices, like cutting someone in half and looking up from the feet. Kidney cancer usually begins in the cortex of the kidney. As it grows, it is initially limited by the capsule of the kidney, then the fat, and finally Gerota's fascia. It also may grow into the adrenal gland or into the renal vein and even the inferior vena cava. Furthermore, it may spread into the lymph system and the lymph nodes, or into blood vessels and out to other organs of the body. These patterns of growth and spread determine how kidney cancer is staged, which determines how it is treated. The stage of cancer describes the extent to which it has grown and invaded or spread. This is the most important information in determining diagnosis and in planning treatment. There are two commonly used systems to stage renal cell carcinoma: the Robson staging system and the widely used TNM system, developed by consensus among the American Joint Committee on Cancer, or AJCC, and the Union Internationale contre le Cancer, or UICC. The TNM stands for tumor, nodes, and metastases. For every tumor, a stage is given to describe the tumor, as well as the presence or absence of spread to lymph nodes or to distant sites called metastases. This slide shows the most commonly currently used staging system based on the TNM classification. In stage 1, the tumor is 7 centimeters or smaller and is limited to the kidney. In stage 2, the tumor is larger than 7 centimeters but is still limited to the kidney. In stage 3, the tumor may be of any size, with or without spread to the fatty tissue around the kidney, to an adrenal gland, to large veins leading from the kidney to the heart, and/or to one nearby lymph node. By stage 4, the tumor has spread beyond the layer of the fatty tissue around the kidney to more than one nearby lymph node or to other organs such as the bowel, pancreas, lungs, liver, or bone. Recurrent renal cell cancer is cancer that has come back after it has been treated. The cancer may come back many years after initial treatment in the kidney or in other parts of the body. As noted, radical nephrectomy involves the removal of the entire kidney, along with the surrounding fatty tissue, gyrotous fascia, nearby lymph nodes, and usually the adrenal gland, though not always. This surgery can be performed through a traditional open incision or cut in the skin, or through telescopes called laparoscopic surgery. The traditional open surgical approach is chosen for very large tumors, tumors that have advanced locally into other adjacent organs or renal vein and IVC, when previous surgery or other circumstances would make laparoscopic surgery difficult, or when the surgeon is simply more comfortable with the open surgical approach. Prior to coming to surgery, you will meet with your urologist, who is a surgeon specializing in the kidneys and urinary tract. A medical interview will be carried out, and your medications and allergies, etc., will be reviewed. A physical examination is performed, then testing may be ordered to assess the kidney cancer and your fitness for surgery. These tests will determine the stage or extent of cancer to decide if it is localized or has spread elsewhere in the body. These findings are then reviewed, and treatment options, including surgery, are discussed. If you have any concerns, they should be reviewed at this time. Be sure your doctor is aware of all your pertinent medical information, especially regarding the taking of blood thinners that are prescribed or over the counter. Ask about your medications, including what you should continue taking up to the time of surgery. Following this review, you will be asked to sign informed consent for surgery. This is a very important document which indicates that you understand why surgery must be performed, other treatment options, what surgery entails, and what the potential risks are. The side effects of surgery are clarified here, and you should review this before signing. The consent also allows your doctor to perform any other procedures that are deemed necessary to save your life, and to use the assistance of other medical personnel, such as other doctors, nurses, and students. Finally, the consent normally includes a note that allows your doctors to use blood or blood products if deemed necessary to save your life. If you have an objection to this, you must notify your doctor and have this section adjusted accordingly. Once the decision is made, it is time to prepare for surgery. In the days leading up to the operation, focus on living as healthy as you can, eating a balanced diet, and getting some regular exercise. Also very important is smoking cessation if you are willing to try at this point in your life. It has been found that if you stop smoking just prior to surgery, there are distinct benefits regarding anesthetic risk and recovery from surgery. Gathering the support of family and friends around you, as well as other patients who have had the operation when possible, can help ease your mind and comfort you. Try to take other measures to reduce stress as well. Arrange time off work well ahead of time, and organize some help with household and other tasks before and after surgery. Learning about your condition and your surgery through programs like this can also help to relieve anxiety by removing the mystery of what is happening to you. Finally, it is important to understand and come to terms with the expectations of surgery as well as potential outcomes. The night before the operation, eat a light meal, then take nothing by mouth for several hours before surgery. A common instruction is to take nothing by mouth after midnight on the night before the operation. However, individual instructions will vary, and they may include a bowel preparation. Try to get a good night's sleep, as it helps to go into surgery well rested. Finally, as individual situations will differ, follow the advice of your doctor or hospital regarding specific preoperative instructions. On the day of surgery, have someone drive you to the hospital and try to arrive early. You will likely first go to the admitting department and have some paperwork done to check you into the hospital. You will then be checked into the surgical area, where you will change into a hospital gown and meet with a nurse. The nurse will review your medical history and check your vital signs, including your blood pressure, pulse, and temperature. An intravenous, or IV line, will likely be started. Through this, you will receive fluids and later medications. At some point during this process, you will meet with an anesthesiologist, who will administer anesthetic drugs and monitor your vital functions during surgery. The anesthesiologist will review different anesthetic options with you and discuss their merits and potential risks. A common part of the anesthetic regimen used during a nephrectomy is an epidural line, which allows the doctor to give drugs directly into the spinal cord and nerve roots to provide excellent and focused pain relief. This will be discussed and is also reviewed in its own module. Finally, prior to surgery, you will meet once more with your surgeon, and any final concerns can be addressed. If not done already, the site of surgery may be marked as a safety precaution to ensure that the correct kidney will be operated on. Once in the operating room, an intravenous or IV line will be started if not done already. As mentioned, an epidural catheter may also be inserted. You will then be put to sleep by the anesthesiologist, and a breathing tube will be introduced. Other tubes and monitoring lines may then be placed, including a catheter into the bladder to monitor urine output, an arterial line in your wrist to monitor blood pressure, and a central venous line in your neck for monitoring and for giving fluids. Other monitoring devices are also used to check your level of blood oxygen, your temperature, and your level of anesthesia, among other things. The doctors and nurses will then carefully position you on the operating table in such a way as to optimize the ability of the surgeon to carry out the operation. There are several different ways to perform a nephrectomy, therefore there are several different ways that a person may be positioned on the table. These drawings show the two most common positions, one with the patient on her side and the table bent in the middle, and the other with the patient on his back and some padding just under the rib cage at the back. Once positioned, the skin is cleaned with special antibacterial solution, and an incision or cut is made. There are several choices of incision for radical nephrectomy. Classically, a 10 to 20 inch incision is made diagonally across the flank along the direction of the ribs, from the midline of the rib cage to the front of the abdomen. In this approach, a piece of one rib may be removed to allow access to the kidney. The chest cavity and abdominal cavity may or may not be opened during this process of gaining access to the kidney. Another common incision is made in the front of the abdomen just below the rib cage, as shown in the drawing. In this approach, a piece of a rib will not be removed, and the chest cavity will not be entered. However, the abdominal cavity will be entered. After gaining access to the kidney, the surgeon will then tie off its blood supply and remove it, along with its surrounding fat, gyrotous fascia, part of the ureter, some nearby lymph nodes, and often the adrenal gland. The incision is then closed using several layers of sutures on the inside and staples or stitches in the skin. A dressing is applied to cover the incision. If necessary, a chest tube may be placed during the closure process to drain fluid from the chest cavity and prevent air from collecting between the lungs and the chest wall. Once stable, the patient is transferred to the recovery area for further monitoring, and eventually to a regular ward bed. In some situations, patients will initially be monitored in an intensive care unit, or ICU. For the first couple days after surgery, you will usually not be allowed anything by mouth and will not be allowed to move around too much. For this reason, you will have special compression devices on your legs to prevent blood clots from developing. A catheter or tube will drain urine from your bladder into a bag to monitor your fluid output. As mentioned, a chest tube may also be present. Pain control can be managed either through an epidural catheter or through an intravenous line. After a while, once you begin to move gas through your system, you will be allowed to take in clear fluids and progress slowly up to a full diet. Activity will also be gradually increased, initially involving just sitting at the bedside, then getting up and moving around with assistance. The compression devices will stay on until you are moving around well and the risk of blood clots has diminished. Pain control will eventually progress from drugs given through the epidural or the IV to oral pain medications. The bladder catheter is removed once the epidural is out and you are moving around well. If present, the chest tube is taken out when the lungs are expanded and all fluid is removed. Staples or stitches are usually removed before going home. You will be allowed to go home once your doctors and nurses are satisfied that all vital signs are stable, your bowels are working properly, no tubes or IV lines are in place, you are comfortable using only pills for pain control, and you are moving well. Once you go home, keep physical exertion to a minimum in the first couple weeks, and take care to get plenty of rest, eat a healthy diet, and keep stress to a minimum. Continue efforts at smoking cessation if stopped prior to surgery. Your doctor can prescribe medications and routines to help with this in the postoperative period. Gradually return to full activities by 6 to 8 weeks. Understand that it may take some time to feel that you are back to normal again. You may not be able to focus and concentrate as sharply as normal, and your physical energy and stamina may be diminished for several weeks. Sometime after your return home from hospital, you will need to visit your doctor for a follow-up exam. At this visit, your doctor will check the healing of your incision and will discuss the pathology report with you. This is the report issued by the doctor in the lab, a pathologist, who inspects the kidney and tumor and examines it under a microscope. The pathology helps your doctor to decide on your follow-up schedule if necessary and if any further tests will need to be done in the future. If necessary, further treatment will be organized and plans will be made for regular follow-up visits. Most kidney cancer patients undergo a regimen of regular follow-up exams after surgery, including periodic assessment by a physician, blood tests, X-rays, and ultrasounds or CT scans. The exact schedule of follow-up visits will depend on your specific clinical situation, as well as the preference of your doctor. Even when kidney cancer seems to have been completely removed or destroyed, there is always a risk that it may return later on. In fact, up to 30 to 40% of tumors do recur after nephrectomy. It is for this reason that careful follow-up monitoring is so important. Recurrence is less likely for tumors of lower stage and lower grade. If kidney cancer does recur, treatment options may include surgical removal if there is only 1 or 2 isolated tumors, radiation therapy for bone lesions only, and/or biologic or targeted therapy if cancer has spread well outside the kidney. If the other kidney is normal, there are usually no effects from having one kidney removed. The opposite kidney will increase activity to keep the overall function fairly normal. If the other kidney does function poorly, however, partial nephrectomy is preferable whenever possible. If not, kidney function must be watched closely, and dietary precautions may be required. Dialysis may eventually even be necessary. If the other kidney is completely absent or must also be removed, dialysis will be required, and kidney transplant may be considered later. Most patients with a good kidney on the opposite side can expect to live a long, normal life after removal of one kidney when the cancer has been cured. While there are no absolute special precautions for these patients, it is recommended to drink plenty of water, eat a healthy, balanced diet, exercise regularly, Be extra careful with contact sports, and maintain regular visits to a physician. Similarly to removing one kidney, there are usually no adverse consequences of removing one adrenal gland. In the rare event of poor or absent adrenal function on the opposite side, precautions must be taken around the time of surgery, and medications will be required afterwards. The benefit of a radical nephrectomy is that kidney cancer may be completely removed and cured. Cure is usually defined as no evidence of recurrent disease after 5 years of close follow-up. However, late recurrences can rarely occur. This slide shows the cure rates for kidney cancer as defined by the percentage of patients going 5 years with no evidence of recurrent disease. As shown here, generally, the more extensive the tumor, in other words, the higher its stage, the less likely that treatment will cure the cancer. Fortunately, when kidney tumors are diagnosed early, they are usually treated successfully, with survival rates in the order of 75 to 100%. The next several slides will discuss the potential risks of surgery. For most patients, radical nephrectomy is a straightforward and safe procedure. However, it is considered major surgery, and for some patients, the situation can be quite complex. Overall, there is a very small risk of death during nephrectomy of less than 2%. Most of these likely occur in complex cases with high-risk patients and large or advanced tumors. The risk of death should be less for smaller, more localized tumors. Causes of death may include things such as excessive bleeding, heart attack or heart failure, blood clots to the lungs, injury to other organs around the kidney, pneumonia or other infections, and kidney failure. This slide outlines the potential problems that may be encountered in the operating room during surgery. Since our kidneys filter our blood to produce urine and receive 25% of blood pumped by each heartbeat, significant bleeding to the point of requiring a blood transfusion can occur in about 5 to 10% of cases. For this reason, blood is routinely kept available to transfuse if necessary. Several other organs are located near the kidney, and these may occasionally be injured during nephrectomy. These include the bowel, spleen, pancreas, and stomach on the left, and the bowel and liver on the right. These injuries are uncommon and usually recognized and repaired at the time. Rarely, removal of the spleen, called splenectomy, and resection of the tail end of the pancreas is required during left-sided surgery, but usually only if the tumor is locally advanced and will require a complete removal. The lining of the chest cavity, called the pleura, may be cut or punctured during surgery. This is usually done purposefully to gain access to the kidney, and is repaired once the kidney is out. This may require a chest tube afterwards. If a puncture is not recognized, or if a chest tube is not left in place, this can rarely lead to what is called a pneumothorax, which is air in the chest cavity outside the lungs. This can put pressure on the lungs, making it hard to breathe, and it is treated by placing a tube in the chest to let the air out. Risks of general anesthesia will be outlined by the anesthesiologist and are discussed in separate modules. There are also certain rare risks associated with the special positioning on the operating table, such as nerve damage, pressure sores, and back problems. There are other complications that may occur in the first few days after surgery. These include infections of the bladder, wound, abdomen, bowels, or IV sites, ongoing bleeding from inside the abdomen or from the wound, and lung problems such as an unrecognized pneumothorax, temporary poor lung function from collapsed areas called atelectasis, and pneumonia. Some patients experience slow return of bowel function because the bowel is temporarily paralyzed, called an ileus. Pancreatitis and pancreatic fistula are rare complications of nephrectomy, caused by injury to the pancreas with a leak of pancreatic fluid into the abdomen or through the skin incision. A collection of infected fluid in the abdomen, called an abscess, can occur from an unrecognized bowel injury. If the opposite kidney is absent or does not have optimal function, there may be a temporary decrease in overall kidney function, or even kidney failure requiring dialysis, as previously discussed. Wound infections are an occasional risk of any surgical procedure, and are usually prevented by antibiotics given to you prior to starting your surgery. Finally, blood clot in the legs, called deep venous thrombosis, or DVT, or in the lungs, called pulmonary embolus, or PE, may occur from poor venous circulation during and after surgery while the patient is immobile. This potentially fatal complication can occur with any operation, and measures are taken to prevent it, including the use of special compression devices on the legs, drugs to prevent clotting, and early mobilization. This problem may occur while in hospital, or rarely after discharge home. Other potential problems that can occur later are listed here. Minor problems with the incision are not uncommon, such as bulging of the muscle or numbness of the skin around it. This is caused by damage to a nerve that runs under the rib cage to the front of the abdomen, which often must be cut to gain access to the kidney. Actual hernias of the wound, where abdominal contents bulge into the wound under the skin, are rare. Delayed kidney failure may occur in rare cases when ongoing kidney disease causes further worsening of function. Lastly, as noted, cancer may sometimes reoccur. Once home from surgery, please call your healthcare provider right away if you develop a fever, if you become nauseated or start to vomit, if you have uncontrollable pain, if you develop a cough or become short of breath, if you develop swelling or tenderness in the legs, if you develop chest pain, if you have significant trouble urinating, or if your incision becomes red, tender, or swollen. In summary, radical nephrectomy involves the complete surgical removal of the kidney along with surrounding structures. It is performed with the goal of curing or at least helping to control kidney cancer. It is considered major surgery, and as such, a hospital stay is required. It is performed through an incision in the side of the abdomen. It is important to understand several important risks of this operation as outlined in the presentation. Most patients recover well from surgery, and in most cases, the cancer can be cured. These are just a few of many resources available to educate you on kidney cancer and help you find support. These references were also used to assist in preparing this presentation and are available at your local medical library. We sincerely hope that this module has furthered your understanding of radical nephrectomy for kidney cancer. We wish you the best for the future, and thank you once again for viewing this educational program.